All right, hello and welcome to week 4 and AMRI210. So today we're going to go ahead and move away from the head. We get the opportunity to leave the head for a little bit, work our way down the spinal canal. So we're going to cover 2 of these parts of the spine today. We're going to cover the cervical spine and the thoracic spine. And we're going to also start with talking about some common artifacts that we see in the field. So it'd be nice to kind of look at what problems you might run into and what you might see on your images and what are considered artifacts. So we're going to look at that today, as well as going through the cervical spine and the thoracic spine. And yes, I know it could be overwhelming if you've had a chance to look at the research area, but I'm going to circle some of the structures that I do want you to pull away that should help you on the homework and help you moving forward for your boards. All right. So let me share my screen and we'll get started. All right, so let's talk about some of these artifacts that we see. So I think we should start out as, what do you guys think the definition of an artifact is? If I say I have an artifact on my MRI image, what would we say that could be? Be metal. Yep, something clouding or distorting the image, absolutely. Something unwanted, yeah, an unwanted effect on our image, perfect. It's all of the above. It could be an implant, it could be a device, it could be something that is not supposed to be on our image. It could be a distortion from the equipment, it could be a bunch of different things, undersampling of our image. So absolutely. So let's look at some of these artifacts. I pulled out some of the most common ones and the ones that you might find in your homework. This first one here is motion. So if we look at this image here, what is it? What do you think the artifact is here? Like what is it, looking at this image, what is wrong with it?
Blurry.
It's blurry, yeah.
Distorted.
It's just distorted. We can't tell where the disc spaces are very well. Everything's kind of blurry, cloudy. So this patient's moving in there. They're dancing in there. And so we are limited in MRI in how we acquire this data. If we acquire slowly, which we do in MRI with most of our sequences, we start to incorporate some of this motion in our image. And this motion can come from a few different things. It could come from breathing. So this patient might be taking these big breaths in and exhaling, and we're seeing this motion artifact on the image. It could be from the heart beating, right? It could be as simple as just the heart beating in the chest if we're imaging the chest, or thoracic spine. It could be something like peristaltic motion, the movement of our bowel as it pushes stool out. All right, so our bowel's constantly moving. So if we image something around the bowel, it could be, again, there could be some distortions from our motion from that peristaltic motion. It could be a vessel, flow artifact. As blood is pumping through a vessel, we get this movement of that vessel. And so, yes, there's a lot of causes for the motion. So if we start to think of what we could do to remedy those causes, then we can think about what will remedy this artifact. So if the patient's breathing, we have them hold their breath. If the heart is beating, we do maybe some cardiac gating. If the patient has peristaltic motion, I might use glucagon as a medication to slow down that peristaltic motion. I might try to communicate with the patient if they're moving around in there, they're not holding still. I might say, please hold real still. These images are not coming out very well, and we're unable to see what we need to see. There's a question here. Do you suggest people don't eat before the MRI? I don't ever say don't eat to a patient. More like, if people are more prone to using the bathroom, like peeing or something along those lines, urinating, then we would have them restrained from drinking a lot of water before, because these exams could be up to an hour, hour and a half, and we don't want them stopping halfway through. If it stop eating is for peristaltic motion, we probably wouldn't do that, because most of the time, unless we're doing an enterography exam, we're not imaging the bowel. So if it's moving, there's tricks we have. We can do things, we can acquire data very fast. And if we image fast, we can beat that peristaltic motion because it moves very slowly. This motion for the bowel is very slow. We can usually beat it with imaging fast. So there's tricks up our sleeve that you guys will learn next semester. So motion is one of the most common ones. Communication is usually the best thing. If it's communicating to hold their breath, communicating not to move, just talking to the patient if they're nervous and they're shaking in there is usually enough to get them through that and have them stop this motion. Now, for those of you who said metal artifact, This here, if you see those arrows pointing, they're pointing to screws in that person's lumbar spine. So they had a fusion. And so those are screws. And you can see that there's some warping of the image there. You can see a little bit of this dark, whatever it is, and these lines that are here. And there's these bright little streaks and flares. This is what we call susceptibility artifact. And we see this with metal. So if a patient has any metal in their body, we'll normally see this type of artifact in our patient. This dark swelling, voidish looking artifact in our image we call susceptibility artifact. Now, we get this from typically metal. So the patient has an implant or a device in their body. Typically, we see susceptibility artifact in the patient from that. But essentially, all it is an artifact caused by something that has magnetism to it. Some what we call susceptibility or magnetic susceptibility. So if we have an object like tissue, which is diamagnetic, and air, which is paramagnetic, and we have an interface between the two, such as the sinuses, right? If I'm imaging the brain and I have sinuses and then brain tissue, there's a change, a very drastic change in magnetic susceptibility, and we can get this artifact around those areas, depending on the pulse sequences that we use, the different sequences that we use. So this is pretty common. There's tricks that we have. One of the tricks is to alter some of our parameters. We can sample a little bit faster. We can go ahead and use a technique called the MARS technique, not like the planet. It stands for Metal Artifact Reduction Sequence. And so we can use a special sequence to help remove this metal from our image. Right? So it's kind of neat. We just kind of click a button or we use a special sequence and we can reduce this artifact, not completely, but significantly. So we have some tricks up our sleeve. All right, this is called the zipper artifact. And it's because it looks like a zipper across your screen. And what it is essentially contamination. So if you're in the room and you're scanning and you're minding your own business, and let's say you left the door open or you installed new lights in the room and you didn't check to make sure there weren't LED lights. And all of a sudden, you see this streak across your image. And let's say it goes away in the next sequence. And then you get a phone call and you see it again. Well, it's contamination, interference from RF. I caused this, I went in my room and I started making phone calls with the door open as we were acquiring images, and this is what we got. So it was broadcasting RF in the room, we were picking it up as this streaking across our image, this false information. The system can't tell the difference between radio frequencies from our patient or radio frequencies from something external. And we see this with maybe new pieces of equipment we introduced to the environment, new light bulbs that we put in. I once had a site that couldn't figure out why they were having this issue. But I looked at their light bulbs, and they just changed out all their light bulbs to LED light bulbs. So I had to replace them all back to the incandescent, and it was fine. So checking the light bulbs, checking the seals on the doors, making sure that that Faraday cage has its integrity to it, and making sure that any equipment in the room is turned off. We'll get rid of this artifact. All right. This one's probably the most common. It's called aliasing artifact. So aliasing artifact is an artifact that's caused when we have tissue outside of our field of view. So we said the field of view is like the frame around our picture, right? So I have this frame around the picture, and let's say I have tissue outside of it. For example, here, this patient has their butt coming off from this image. Well, I use my field of view and I cut off that butt, all right? Well, what happened was when I acquire my data, the system gets confused and says, oh, wait a second, there's something over here. And it puts it over here in the screen. It flips it across your screen. It wraps it around on your image. So this is the patient's butt. You can see the coccyx over here. And that wrapped around from the back of this field of view to the front. And that's aliasing artifact. That's if we have a, oh man, I messed up moment in our scanner. We have a field of view. We forget to either open up our field of view big enough to include everything, either use special techniques, what we call anti-aliasing techniques. It sounds fancy, but it's just a technique that we can sample a little bit outside of our field of view to compensate for this artifact. But typically it's I made a mistake, got to rerun it. So I reran this one. I ran this accidentally and I saved it as an image. It's a prostate MRI. So we can see the prostate over here. Here's the bladder. And it's not really in the anatomy. So I didn't repeat this one per se, but I probably could have or should have. But this wrapped around to the front of the patient. Now we have flow and ghosting artifact. So flow and ghosting artifact are, again, some common artifacts we'll see. Here is the descending aorta. And the descending aorta, we can see that there's a couple of them. It's ghosting across our image. So this thing is pumping blood, it's moving to a new location and moving back and forth. As I'm acquiring data, I'm tricking the system, and the system's saying, hey, wait a second, there's more than one descending aorta, and it's mapping it in the image incorrectly. So we get this incorrect mapping of this artifact. Here we have cerebrospinal fluid coming down the spinal canal, and as we acquire information, we saturate out some of that cerebrospinal fluid, creating this dark voids in our image here. It looks like possible little lesions. And so rads hate that. It confuses them, but it's flow artifact. And we can use different tricks in our sleeve, something called gradient moment nulling or saturation bands, things you might have read about. But those are typically our tricks to get rid of this type of artifact. This is something that we're going to talk about a little more next week, crosstalk. Crosstalk is very common in the lumbar spine. So anytime that you have slices that are overlapping, you get this, this type of artifact. Let's see here. This is caused because of movement. Correct. Diana, that's correct. It's caused from movement of something. It's not really the patient. They have no control over that. It's their vascular moving blood through their vessels, or it's flow down their cerebrospinal canal. But you're right. This last one here is kind of involuntary motion that we get in our image. Yep, you're welcome. This one here is caused when we have overlapping slices. So if we were to, I'm going to just quickly draw a lumbar spine. All right. And if I'm taking slices through it, these disc spaces here, some of these slices may overlap. And if they overlap, I get this dark line of suppression across my image. Now, there's not much I can do if I'm angling through these disc spaces, right? I'm kind of stuck with that angle. But as long as this line is not in my field or what I'm imaging, like the spinal canal here, it's fine. We would never repeat anything for this. This is just something that we would expect to see in our image, but it's an artifact. It's caused from overlapping slices. Slice overlapping another slice. This is one called herringbone or corduroy artifact. And this is kind of a funny one. This artifact is caused because of one incorrect data point on this entire case space. So if I were to draw this data space that we're collecting from our patient, and I'm filling this and turning this into an image, one part of this data space is corrupted, we get this artifact throughout the entire image. We usually get this from a surge of power in the system or dust in the plug. So typically what I would do in this situation, so when I saw this artifact, what I did was I went in the room, I pulled out the plug from the table, and I treated it like one of those old Nintendos where I would blow in the plug, blow in it, get all the dust out, plug it back in, works perfect. If it doesn't, then we would call for service. This is called chemical shift artifact. We don't want to see these dark lines around structures in most situations. Sometimes we do, but most of the time, this is an artifact that we see in our image where we see these dark bands around our organs where fat and water meet. So fatty tissue meets water tissue, we get this dark border. And that is an artifact that we see in our image. And we don't usually like that, so we can rerun this sequence, change a few parameters, and rerun it and get rid of this artifact if need be. All right. So it's pretty easy to get rid of this artifact. All right, let's just do a quick little review. I know, I'm sorry. Someone had made that comment last time too. Let me see how tiny they look. I know, I'm so sorry. It just shrinks it. Here, I'll mag it up here. So hopefully this is somewhat helpful. Oh yeah, you can click on them. Yeah, there you go. Thank you, Liam. It won't work on the iPhone. As long as you can look at them and kind of see if, just kind of pick them out and do the activity in your head, I'd be happy with that. So as long as you can try to match them.
Professor,
Yes,
I have a cool question.
of course.
Yesterday, you mentioned that we're allowed to speak to the patient while they're doing their exam, correct?
When they're doing their exam, yes. They
Okay.
they might not be able to hear you very well over the loud noise, but we'll get pauses.
Okay.
So like, yeah.
Because there's a question on the knowledge check and on the quiz
Yes.
in regards to like what is not allowed while they're in the machine. And I guess that is the correct answer, that we're not allowed to speak to them. So is like, are we?
You have to communicate with your patient, because if they're dying in the scanner and we don't know it, we have to be able to say, "Are you doing okay, Mr. Smith?" And if they say yes, I'm doing fine, then we know they're doing okay. But we have to be able to communicate. Legally, we have to have some line of communication with them. We give them a panic ball, and then we have to talk to them, communicate. Some sites actually write you up if you don't communicate. Let me look it up.
It's the one where like the patient has like some glasses or something like that. Like, I don't know.
It was 200 and then the knowledge check, you said?
In the knowledge check, yeah.
All right, let me open it up here and see here. Because someone brought me another question too, so I have to submit these questions to get them fixed. So there was another one too that we had gotten fixed, but knowledge check week 4. All right. Let's see here. All right, let's see here. So 1 second, see if I can find it. Okay, so what is this device and what is it most likely to use? Is that kind of what you were referring to? I don't want to.
Yeah, it's that one.
Yeah, it's kind of, let me see if I can, it's the one that looks like this. Does that look familiar?
It's not showing on the screen.
Is it, okay.
Oh, now it's showing on the screen.
This thing right over here?
No, it's not that one.
It's not that one. All right, let me see.
But it's the one that Michael put in the chat, which is not generally accepted technique for helping patients overcome
Which is not a generally
claustrophobia.
accepted technique for helping patients overcome claustrophobia. Let's see here. Let's see. I'm not seeing it. Yeah, I'm not seeing it. Do we have a number by any chance on that question?
No, but I can go back to my knowledge check and pull it up and send you a picture of it if you'd
Yeah,
like.
'cause I'm looking at it, I see, and I wonder if you guys don't have the same ones, like if the questions are random, because
If I'm not mistaken, it wasn't in knowledge check. It was exercise number 1.
Oh, exercise number 1.
Yeah.
No, it's on the
Mhm.
knowledge check too.
Yeah, because
Yeah.
I have mine on exercise number 1.
Yeah, no, I did the knowledge check today and the exercise and the quiz, and it's all on the 3 of them.
All right, let me see
I
if I
mean,
can find.
again, maybe it's just me, I don't know, but I was just a bit confused with it, but
No, that's okay. I want to make sure it's clear. And if there is something that was on there wrong, we have to get it fixed. So I want to make sure that we get these all fixed. If so it's a picture of a lady wearing glasses. All right, let's see if we can find that. I'm not seeing a picture of a lady wearing glasses. It was the first exercise and the knowledge check. I didn't see it in the knowledge check. Let's see. If you guys do get you run into, I don't want to hold up the class. So if you guys do get a number to the question, I'm going to leave this open and check it again after class. Question 3 on the first knowledge check. All right. Okay, let's do that. So it might be random. That's makes it a little tricky. I got to check on my 4th attempt. Okay, let me check it here. Question 4. I'm not seeing it. And it's on week 4?
yes.
I'm gonna have to go and try to find it. I'll try to find it, but I can't see it on here.
Okay, no worries.
All right, perfect. But yes, you can. You'll have to communicate with your patient. If they're claustrophobic, I wonder how the question's worded. If it's worded like, is it going to help? I don't know. I want to see the wording on it, but it sounds confusing. Let me see. You guys wrote in there what the wording was. Let me scroll up. Which is not a general accepted technique for helping patients overcome claustrophobia. Accepted technique. Oh, it's probably, I'm going to look at it, but it's probably saying, what's a good technique for you to help a patient overcome claustrophobia? Me just talking to them over an intercom doesn't help them. It's going to be just checking to make sure that they're not in panic, or if they need to be pulled out, and if they're physiologically okay. So I'm only communicating to give them heads up. This next sequence is going to be 5 minutes. John Smith, are you doing okay in there? I'm not really going to be checking on his claustrophobia. If I do that, I'm going to go into the room, talk to him, and make sure he's okay that way. But I want to check the question and see if that's kind of where it's at or not. So, but you do need to talk to your patient regardless. All right, let's keep going here. General anatomy. Bony curvature in joints of the thoracic, lumbar, cervical, sacrum, all of the spine components. We have these curves. When the curve bends towards the ventral part of the patient, it's a lordotic curve. So we've got 2 of these curves. 2 lordotic curves. And then when it curves the opposite way, we have a kyphotic curve. All right. So we have 2 different curves of the spine, and it's based around the idea that we want to have some cushion when we walk. So we have certain numbers of vertebrae in each section. When we look at the cervical spine, we have 7 cervical spine vertebrae. So cervical spine, we have 7 vertebrae. So we'll count those, and this is how we are able to identify where we are in the spine. Do I have enough coverage for the C spine? Do I have enough coverage for the T spine? If I know how many vertebrae are in each section, I can guesstimate where my coverage needs to be. All right. So we have the thoracic spine, and the thoracic spine has 12 vertebrae to it. The lumbar spine has 5 vertebrae to it. All right. The sacrum has 5 fused vertebrae. And then we have this coccyx down here, and there's usually 3 to 5 fused vertebrae. It's basically a remnant of a tail that we used to have. All right. So this shape allows for flexibility, allows us to turn, move, have impact when we walk, so we don't get hurt. So this design is built for impact. Now, some patients do come into us and have straight spines. So their cervical spine might be straight. Their lumbar spine might be straight. And that'll be noted in there. And that could cause some issues with herniated discs or other issues like that. Just because they don't have that same impact cushion as they walk. So if we look at it from a side view here, we can see all the vertebrae. But today we want to focus more on the cervical and the thoracic spine. And the cool thing about the spine is if you can image one part of the spine, you can image the entire thing because everything's the same. You're just covering a different area. The same pictures, the same views, the same sequences, everything's the same. The only difference is where you actually are in the spine and how much you're covering. So vertebrae look like this here. So this is a side view of the cervical spine, like a sagittalish lateral view. And this is an axial view. So if you took this vertebrae out, flipped it, and looked at it, you'd see this body part over here. The body's right over here. You'd see this part protruding out the back of the patient, the spinous process. We've got a spinous process over here. You'd have these 2 joints, the superior and inferior articulating process. And this allows these to stack on top of each other, kind of like those connect blocks or Legos. They just connect on top of each other and stack on top of each other. And they articulate with these joints. All right, so we have these joints where they articulate. In the cervical spine, we have a hole in this body that protrudes out the side. This is called the transverse process. So what I want you guys to remember about these are the ones I circled. The body, the spinous process, the transverse process, and these stick out the sides. All right, and then these articulating processes, superior, inferior articulating process. All right, there's 2 more that I'm going to point out, but let me just talk about these really quick. When we go through the entire spine, every vertebrae, no matter where you are between the cervical and the lumbar spine, all have a body, a transverse process, a superior inferior articulating process, and a spinous process. They all have these. So you don't need to reinvent your way of thinking when it comes to this. You're going to have a transverse process on every cervical, thoracic, and lumbar vertebrae. You're going to have a spinous process on every one of them. You're going to have an articulating process that can stack on top of each other. And you're also going to have these 2 structures here. A pedicle, let me spell it up here, and a lamina. All right. So we have these 2 processes, and what they do is they form this canal. You can see it kind of, we got one part here, this pedicle and this lamina, and they form this huge hole in the middle of this vertebrae. Can anyone guess what goes through that little, or that large foramen, that large hole? The cord, absolutely, the spinal cord, perfect. So the spinal cord goes through this, so we need a space. We need this space to go through it. All right. I was just reading some of the chats up there I missed. All right, perfect. So we've got these structures here. So again, what I want us to know, the body, the spinous process, the transverse process, these articulating superior inferior articulating process, pedicle and lamina. The beautiful thing is, if you memorize this on one of these vertebrae, you just memorized all the structures from an axial standpoint on the cervical, thoracic, and lumbar. So it just makes it easier for you. And we're going to look at them. These vertebrae are just shaped slightly different. So they look a little different, but they all have the same processes on them. So you're going to see in a second what these vertebrae look like and how they differ in this next slide. So this is a cervical spine. This is what a thoracic spine looks like. All right. This is flipped upside down, but still, this is your body. Your spinous process, it looks a little different. It just is one finger-like structure that protrudes at the back. We got these wings on the side, these transverse process. We got articulating processes here. These facets, articulating processes. We've got that foramen in the middle where the spinal cord goes through. And the only thing that's different on a thoracic spine is we have a rib attachment. So our ribs attached to the thoracic spine posteriorly. So we have to have some type of facet to hold the ribs on this thoracic spine. So we have this facet for the head of the rib, and it attaches right here. So it'll come out here and protrude around the patient. We can see it from a side view here. Here's that spinous process. Here's the body. Here's that superior articulating process. We have the transverse process over here. Or actually, I'm sorry, that's a costal. Here's superior, inferior articulating process. And here's where the ribs attach. Right. So again, we're hitting the same structures: the body, spinous process, transverse process, superior inferior articulating process. All vertebrae in the thoracic, lumbar, and cervical have this. So let's quickly look at a lumbar vertebrae. All right. Now we're moving down the spinal cord canal. We have this spinous process here, this protruding body part here posteriorly. We have these side protruding body parts here, transverse processes, and we have the body. They all have the same structures, and we still do have a superior inferior articulating process. They stack on top of each other. So you can see them articulating and stacking. All right, let me see here. Is there any image like that one on our knowledge check and assignments? That's a good question. Let me take a look really quick. Well, I take a look, there's another question here. Do we need to know the names of the curves? You just need to know lordotic and kyphotic. So yes, you do need to know those curves. All right, so the question is, any one of those images on our knowledge check? It does not look like it. I'm looking at the knowledge check right now, and I don't see it on there. All right. So yeah, kyphosis is a disorder, like hunching disorder. All right. So let's go back and look at the cervical spine. Now we're going to focus on just the cervical and the thoracic today. There's a lot of structures here that are listed on this picture here, but I'm going to pull out 3 or 4, maybe 5 of the ones that you definitely need to know moving forward. All right, so the first one that we're going to talk about is this guy right here. This vertebrae, it looks like a, I don't know. I don't know what it looks like to get like a little triangle vertebrae. It looks a little different than the other ones. These look like nice little squares. This one doesn't. And this is what we call cervical spine 2. There's a total of 7 vertebrae in the thoracic spine, or the cervical spine, I'm sorry, cervical spine. This is the number 2. And the reason why it's so important, it does look like an arrowhead. I like that, an arrowhead. And the reason why that's so important to identify is this is how we make sure we have all the vertebrae when we're taking images. I don't know if I have all the cervical spine images unless I can count them. And it's hard to just pick one out of the hat and say, all right, well, what vertebrae is this? Well, there's a bunch here. I don't know what's what. But if I can identify 2, I know that this one's 3, which means this one's 4, this one's 5, 6, 7. Well, there's 7 cervical spine, and I know that the cervical spine ends here. T1 is over here, thoracic spine 1, thoracic spine 2, so on and so forth. So this is the dividing line for the cervical and thoracic spine. So if I can identify this arrowhead, I'm good to go. I literally could count this entire spine and make sure that I have it. And Anthony, you got me right there. I was literally going to get into this one. So where is C1? So look at C1 right here. This wraps around this process, this finger-like protruding process on C2. So this process here on C2, this arrowhead, is called the odontoid process. All right. A lot of times, you'll if a patient gets hit in the head or in the neck, they'll fracture that. This C1 sits around it and allows us to turn our head from side to side. Right. So it wraps around it. There's a better picture here. Let me go back up to here. So you see how this vertebrae right here, this protruding arrowhead structure comes up into there. C1 wraps around it and allows the head to turn. So it wraps around this one. And that's where we find C1. All right, let me go back up here. So we have it right here. This is the atlas, and the axis is C2. So atlas sits on top of the axis. All right. So we have to be able to identify C2. That is super important. We don't know if we cover the entire cervical spine unless we can identify C2. All right. So that becomes really important for us. The next thing that becomes really important for us is looking at some of these ligaments here. We have this anterior longitudinal ligament. It's this ligament that runs the entire length of the spine. And it goes all the way down here. We look at this, and this basically is a support for the spine. It maintains that curve anteriorly and makes sure that there's no discs protruding anteriorly, because we can have disc herniations herniating forward, not just back into the spinal canal. If we have one anterior to the spinal body or the vertebral body, we can have one posterior as well. And if a patient has a herniated disc, it usually pushes this ligament out into the cord area. All right, so that's the posterior ligament. Your homework likes to talk about this ligamentum nuchae. And it's this huge, it looks like this huge ligament that runs all the way, wow. Runs all the way down here. It's huge ligament. All right, so we should be able to identify that one fairly easy. Is it really important for us from a imaging standpoint? No, but the radiologist might find that more important to see if there's any potential issues with that patient. It does support the head, so it does have some support process there to support the head as it moves. And then finally, we have this supraspinatus ligament. Supraspinatus ligament connects the tip of the spinous processes over. Every one of them has their own spinatus ligament, but it connects the tip to its origin. So we got a bunch of these supraspinatus ligaments. So on this picture, this is all I would want you to know. All right, C2, super important. Your anterior, posterior longitudinal ligament, ligamentum nuchae, and supraspinatus ligament. We have redundancies in the spine. And one of these redundancies is how a disc is structured. So if we have a disc here, this is a cushion. Think of it as kind of like a mattress in between each body of a vertebral body. Every time you jump, every time you move, it's kind of just cushions that. All right. We need to understand some of the layers to this. And we're only going to talk about two of these layers. We have a central layer, which is called the nucleus pulposus. Let me erase that just so you can read it. I'm just going to put check mark by it. Not that close. Nucleus pulposus is the center of this disc, this cushion. The outer layer is called the annulus fibrosus. It's kind of the annulus fibrosus is this tough material. It's like a cartilage, but the gel-like substance inside of the nucleus pulposus, this gel structure is what that cushion is. All right, so here's a question on the image. It says mid-sagittal. What does that mean? Oh, that's a good question too. Mid-sagittal, where did you see mid-sagittal? Mid-sagittal means right down the center. So if you were to cut the body into literally two halves, directly halfway through the body is your sagittal plane, your mid-sagittal plane. So if you cut the body right down the center, right, not off to the sides, right down the center, right to the nose, all the way down the spinal canal, that's the mid-sagittal plane. So there's one slice in the body that's your mid-sagittal plane. It's right down the center of your body. You can have a bunch of sagittals, but there's only one mid-sagittal, right down the center. All right, so this is a mid-sagittal plane. It's cutting the body into halves. We can see the spinal cord, the vertebrae right down here. I can see one half of this patient here. So this is a mid-sagittal plane. All right, this image here is not a mid-sagittal plane. And this is actually, I think, an image of one of the instructors here at the school. I just found that out this week, which I thought was kind of neat. They loaded their own images up here. But this image here, we have to identify some of these structures here. This line here is called the vertebral artery. Let me write that down here. And if you guys are thinking, hey, I've heard of vertebral artery before, we talked about it in the circle of Willis. It's the same one. It's the same one that goes all the way up into the brain and connects to that basilar artery. Over here, we have a joint. You can see these joints attaching. The superior inferior articulating processes are connecting to each other. And this is called the zygapophyseal joint. So it's a mouthful, but it's a zygapophyseal joint. So those are just the two structures that you should probably know on an image that's not mid-sagittal, right down the center of their body. This is a slice off to the side. Yes, facet joints. Yep. You can, they're anything that's a joint in the spine where something connects, it could be a facet. They typically goes by a zygapophyseal joint, but yes, they're facet joints as well. That's just like the generic term for it. All right. So just a quick, I don't want to get into lumbar too much, but this is just something to kind of just look at, just so we can compare. Right? We talked about the cervical spine, the thoracic spine, not quite yet, but we will. This is just kind of tying it together, all right, with the lumbar spine, the entire vertebral column. And so we have that anterior longitudinal ligament we talked about that came all the way from the cervical spine down. It's this dark line that we see here. All right. This dark line here. So this is the anterior longitudinal ligament, which we talked about already. We have a posterior as well. It's this dark line back here. All right, so this is just showing that it's running all the way down the spinal canal. Right. Here are some of the nerves that we would see branching off here. This would be part of the lumbar spine. You can see that we have nerves branching off the sides. I'm not going to get too much into this because we're going to talk about this next week. Next week's about the lumbar spine, and then we'll just focus on the lumbar spine at that point. Here's all the nerves that we see. One of the things that I wanted to bring up in this is this brachial plexus. So this is one of my favorite exams to do, all right, because it's so hard to see these brachial plexus, or nerves. Brachial plexus is a bundle of nerves that branch off around C5 to T2 area, and they branch out down the arm, and they allow for sensory and motor nerves of the hands and arms. Now, if a patient has an impingement, I've scanned people who've had tumors on the brachial plexus, and it's the weirdest thing, because I remember one patient, I felt his hand where he had the tumor on that brachial plexus, and it was ice cold. His other hand was normal temperature, but he said he's always cold on that side. And it's weird because this brachial plexus has just weird nervous system functioning of the extremities that you see the weirdest things with these people. They can have issues where they're just in extreme pain in their arms, or down that arm, they have this shooting numbness, tingling. It's just very weird how the brachial plexus can manifest a lot of very off the wall symptoms for patients down their arms. But this is just a bundle of nerves that branch off the spine. We have another one, the lumbar plexus over here, and the sacral plexus down here. All right. If we're going to talk about the sciatic nerve next week, and that branches off the sacral plexus. All right. So here's what kind of a nerve looks like when it branches off. We have the vertebral body here. We talked about the annual fibrosus, this very hard, like part of the mattress that rests in between these vertebral bodies. And the center of it is the nucleus pulposus. So I pulled this from your readings. All right. So we have different nerves. There's dorsal nerves and ventral nerves. We're going to talk about those next week. So yeah, I don't want to get too much into this because I don't think that we need to get too much into the lumbar spine until next week. But here's a close-up of those plexus here. Here's a close-up of that brachial plexus. These nerves branching off. So we have a cervical plexus as well, which has the phrenic nerve. The phrenic nerve is actually an interesting nerve. For any of you who get the hiccups, that is an interruption of the phrenic nerve, which, say from an evolutionary standpoint, that's a reflex of us gasping for air when we used to have gills. And it just never went away. And it's based on how long the phrenic nerve is. In theory, the phrenic nerve really only needs to be pretty short, but because we've evolved in the way that we have evolved, it's stretched out this nerve, and we could get these same symptoms that we get when we were gasping for air as we were fishes if we were out of water. So we can get this issue of hiccups, and that branches off the cervical plexus. But the brachial plexus is a little different. You can see it's coming off on C4, C5, going all the way to T1. And this controls a lot of the nervous system down the extremities. We have two of them, a brachial plexus on the right and a brachial plexus on the left. Like I said, we have a lumbar plexus and then a sacral plexus. This image here, and I'm going to ignore these for now. So let's just ignore these for now. This should look somewhat familiar. This is a neck. So picture this as a neck. And I'm going to draw shoulders, ear. This is supposed to be an ear. This is supposed to be a head, by the way. All right. So here's the head. Here's that circle of Willis. And here we have this vertebral arteries coming up here, coming together and meeting and making this basilar artery. So we have vasculature inside the neck. And a lot of times you guys are going to be doing MRAs of the neck. So they're going to they're going to be looking at all those vessels. They want to see the vertebral arteries. They want to see the carotid arteries. And we want to make sure that we're including all of that. All right. So let's go ahead and do an activity here. Let's see if I can find that question. Oh, I see it. All right, I'm looking at the question now. I found it. I'm going to bring it here. I hope I'm not giving anything away from a. I don't think there's anything on there that's incriminating. But the question is, which is not a general accepted technique for helping patients overcome claustrophobia? Talking to a patient during a scan. Well, we can't hear them. They can't hear us if we're talking to them during the scan. Talk to the patient in between scans. Yes, we should. Putting a mirror mount on the coil or prism. That's something we can do. And that's what this thing on our face is. It's a mirror thing. Or we couldn't put a blindfold or sedation. So do I think that this is a good worded question? Absolutely not. And I'm still going to report it. But the patient's not going to hear us if we talk to them during the scan. But talking to them in between the scan, they can. It's a play on words. I'm going to still report it and see if we can reword it better. Because I agree, I don't really like it. All right. For time's sake, I'm gonna keep going. I think most of you guys have submitted too, so we're just waiting for a few. Take your time. All right. So let's talk about performing these exams. So if we are setting up a cervical spine, we want to make sure we screen our patient, make sure there's no metal in their body, they have no devices in their body that are MRI unsafe. Now, they could have a joint replacement. If it's MR conditional, that's perfectly fine. But if it's something like a neurostimulator that's labeled MRI unsafe, that would be a potential problem. But we go ahead and investigate anything that the patient might have in their body, see if we can scan them with it, and we're good to go. Change our patient out of their street clothes, get them into position, head first, supine. We use what we call a neurovascular coil or an NV coil. And that is just like literally a helmet that goes on over their head and neck. And then we landmark right in the center of their neck, right where we're going to be imaging for a cervical spine. And then we could go ahead and just cover this area. Now the question is, and we already answered this question earlier, is how do we know if we have the entire cervical spine? Well, we have to identify C2. And we see this arrowhead over here. So this is C2, 3, 4, 5, 6, 7. And I even got T1 in here as well, just because I wanted to include it all. Make sure I had everything in there. And then I would go ahead and make sure my sagittal view, I'm covering this entire area here. Now, if I'm doing a sagittal, I need two other views. I need my axial and coronal view. And then I'm angling to the mid-sagittal plane on this. You can see right down the center of the patient's body. Right down the center here. So I'm angled to that mid-sagittal plane. I'm covering from transverse process here on this side to transverse process on this side. You can see it a little bit better here. Here's a transverse process, transverse process. And I would get my sagittal view. For an axial, I just need to cover that entire cervical spine, separating the body into a top part and a bottom part, right? This axial slice, cutting right through this patient. And if this is the spinal cord, you can see that my slices are going to be perpendicular. This is my slice. This is the spinal canal. My slices are perpendicular to the spinal cord. And if I'm perpendicular to my images should look something like this. Really nice, clean image. Right. Coronal images are rare. We only run these if a patient has scoliosis. We want to see on scoliosis the side curvature of the spine. So we only run coronals for scoliosis. And then we're just angling going from the posterior to anterior, covering the entire cervical spine. I don't care about anything else besides the cervical spine when I'm imaging the cervical spine. And if a patient has scoliosis, their coronal image, the spine would look something like this. Now, this is extreme scoliosis, but I've seen pretty extreme before. So it does look sometimes wild. So if we run this sequence, these are some common sequences that we would run. Typically from an American College of Radiology, from those documented papers, these are the sequences that are the gold standard for imaging any part of the spine, from the cervical to lumbar. A T2 sagittal, a T1 sagittal, and a stir, and then axial T2. You guys are going to learn about something called an T2 star sequence, and I'm not going to get into that, but it helps us look at the nerves in the spine sometimes. So that's something that helps us look at those nerves in the spine. We might give contrast to the patient. If the patient has a tumor, has an abscess, has an infection of some sort, we're going to probably give them contrast, and we would do an extra T1 and put a fat saturation technique on. I'm going to remove all the fat from the image. So all I see is anything bright from contrast. So we run that before the contrast and after, or what we call pre and post. And then we do sometimes a flare sequence is what we call it. It's a fluid attenuation recovery sequence. It makes water look dark. So let me talk about these a little bit here, maybe. So water looks dark on a flare. On a stir, fat looks dark. So we remove those tissues from our image. We take them out. We're no longer confused by the signal from fat or from water itself. We're looking at true pathology at that point. So if a patient has multiple sclerosis, which is MS, we run a flare sequence to get rid of all the fluid, cerebrospinal fluid, in that area that we're imaging. And anything that stays bright is a multiple sclerosis plaque. So the same thing for the brain, we run those flares for the brain, well, we run them for the spine as well. For the thoracic, the setup is almost exactly the same, except we need to cover the thoracic spine. Now let me ask you guys this question. I love asking this question. How do I find T1? How do I know where T1 is? Oh, I love that. Jerry, you got it. I try to find C2. Okay? So I go up here, I find C2, so I have to run one image of the neck. 2, 3, 4, 5, 6, 7. Found T1. So if I put my slices with the top of it above T1, I've included it. So let's say that this is T1. T1. We actually write on here. Maybe. 1, 2, 3, 4, 5, 6, 7, 8, 9. How many vertebrae are in the thoracic spine? Perfect, 12. So I'm going to keep going until I get to 12. Got it. All right, I even got a little bit more than I needed. But this is all I need to cover. I go from transverse process to transverse process. And I get my good sagittal image. For axials, this looks a little confusing. It's like, oh, wait a second, I got 2 boxes, man. What are you doing here? What's going on? What I'm doing here is I've got this curve here. All right, this curve in the spine. Now, this curve makes these slices not so axial. I want to be axial to the spine. So I do a top and a bottom. I angle the top to the top curve and the bottom one to the bottom curve. The only stipulation in this, if I do this, is I have to have overlap. And I do. So there's no gap here in this slice where I'm missing something. I'm constantly getting something. And if here is my canal, I want to be as perpendicular. My slices have to be as perpendicular as possible to these blocks of slices. All right. And don't worry, you guys, next semester are going to go through all this again, this planning part of it all. So here's a question. Can you tell us what protocol these images are? This is the thoracic spine. So we're doing a thoracic spine axial image. So let me write axial up here. Surprised I didn't put that up there. Axial set. So to get an axial image, I need to use my sagittal and my coronal, the 2 other views. All right. Here we've got a coronal image. We only do these for scoliosis, the same as the cervical spine. And we just cover the entire vertebrae, all those vertebrae from T1 all the way to T12. Some sites like you to get a little bit more. It's up to whatever your radiologist's like. If he's asking T2 or T2 star, these are T2 weighted images, but the protocol is going to be the same as it was for the cervical spine. We do the T2, the T1, and the STIR and the sagittal plane, and then axial T2. So we'll probably do an axial T2. This is probably planning up an axial T2. So here is a protocol. We would do a sagittal, T2, T1, and STIR. So we do all of these sagittal views that you see here. This one we'll do as a T2. I'll run a sequence as a T2. Now I'll rerun it as a T1 and rerun it as a STIR. So I'll have 3 separate sets of images. One is going to be a T1, one's going to be a T2, and one's going to be a STIR. And then for my axials, I would plan this axial as a T2 through the entire vertebral thoracic spine. All right. Then we do pre and post. And we've got another little exercise here. This is a quick one. Yeah, so there's 3 separate. We're doing 3 separate for that sagittal. All right. So let's look at some pathology. So the discussion question here is going to be, what would you think could be a challenge when imaging the thoracic spine? So the first part of the discussion is, what do you think a challenge would be when imaging the thoracic spine? And then the response is going to be, what could be a remedy to this? All right. So let's look at this here. We have Chiari malformation. We kind of talked about that last week when we said we have that tonsil herniation. And this one's an extreme one. You can see this tonsil is coming all the way down here and pinching off right here. And this is swelling up very bad. This is starting to create that hydrocephalus. All right, so this herniated down, causing a huge issue. Let me erase this so you can appreciate it even better. This should be up here. And it's definitely not. So that's very impressive. And so one thing that I do want to point out for a Chiari malformation is that this is the #1 cause. Why does that happen? It's just sometimes happens. Some people are born with it. Some people have issues. I've heard stress cause it, extreme stress. Most people are born with it, and then you just get swelling in that area. So we image babies sometimes, and we'll see that there might be some Chiari malformation starting to appear, and then over time, it just gets worse and worse and worse. So it's the #1 cause for something called a syrinx. And we're going to look at an image of a syrinx next. All right. But this is the #1 cause for a syrinx. So typically when we see this, we see something that looks very similar to this, a syrinx. And this person does have Chiari malformation. You can see the herniated disc, or I'm sorry, herniated cerebellar tonsil. And we see this backup of fluid in the spinal cord itself. All right, so this is a syrinx. It's essentially this big cyst-like structure inside the spinal cord, and this is extreme. Right, so that's a syrinx. Here's a huge tumor on there. So I believe I scanned this one, and I believe that this patient was unable to feel their hands, I think. I want to say there was something extreme. That's a tumor coming off into the spinal canal, pushing on the spinal cord. And typically when we image spine, we're going to be imaging for the fact that we might be looking for a herniated disc. So this is a herniated disc bulging out. All right, we see a little bit of the bulging here. We can see back up here, this posterior longitudinal ligament coming down. And we can see that posterior longitudinal ligament stretching. Here, let me erase. So you can look for that ligament. But if this protrudes to the point where it pushes on the spinal cord, we call that cord comp. If a patient has cord comp, they could be paralyzed if they move funny, if they sneeze, if they get into an accident. It doesn't take much for them to do some damage to their spinal cord. So radiologists are typically asking us to say, well, do you see anything suspicious? If you do, then let us know and we'll clarify if it's cord comp or not. But don't assume that it's not, and don't assume that if you think that there might be some sense of cord or some cord comp, let a rad know. That's typically the rule of thumb out in the field. So if you see something where this disc is touching the spinal cord, you want to let someone know. So it's usually an emergency. You might get called in the middle of the night for suspected cord comp. And most of the time it's not cord comp, but you never know. Here are these hazy structures here. That's multiple sclerosis, right? Some demyelination of this spinal cord. So it's multiple sclerosis. All right. So here's the last exercise for the class. When you finish this, you're all done. It's really important to know that cord comp is one of the things that we don't mess with. Those are like the only stat that we have in MRI. Everything else CT can do for the most part. But that and like an API for pregnant patients, if ultrasound can't rule it out, but typically ultrasound is the first sign for that, but nothing can see the spinal canal like we can. So we are anything with the spinal canal, and that's an emergency situation, cord comp. They need us for that. And you'll get called in the middle of the night for those. They don't happen often, so don't like freak out like, oh man, I'm never gonna sleep again. You will, it doesn't happen often, but if you know, some sites now do have 24/7 coverage for MRI techs. CT can't see that subject contrast very well between cerebrospinal fluid and a disc. So it's very hard for them to rule that out. So that's why they need MRI. MRI, there's no question. It's you know, dark disc on bright cerebrospinal fluid. In CT, it's dark disc on dark cerebrospinal fluid. So it's dark and dark. It's hard to see the contrast there. So CT is not typically used for ruling out something like this. Not to say it can't be, but no physician typically wants to go subpar and make a complete call on that. Because it could risk the patient. Patients could be paralyzed if they make the wrong call. All right, you guys have a great evening.